Cardiac tamponade. Cardiac tamponade is a life-threatening emergency caused by the accumulation of fluid in the pericardial sac. The increasing intrapericardial pressure compresses the heart chambers, particularly during diastole, impairing ventricular filling. This leads to a reduction in stroke volume, cardiac output, and ultimately causes hypotension and end-organ hypoperfusion. If left untreated, it may progress to cardiogenic shock and death. Epidemiology. Cardiac tamponade can occur in individuals of any age, but the risk is highest in patients with conditions that predispose to pericardial infusion, including acute pericarditis, metastatic malignancy, especially lung, breast, and hematological cancers, chest trauma, penetrating or blunt, post-myocardial infarction, especially in the setting of left ventricular free wall rupture or Dressler syndrome, uremia or renal failure due to pericarditis secondary to uremia, and autoimmune disorders, for example, systemic lupus erythematosus. Pathophysiology. Cardiac tamponade occurs when fluid accumulates in the pericardial sac, raising intrapericardial pressure. This pressure prevents adequate diastolic filling of the ventricles, reducing stroke volume and cardiac output. The rate of volume accumulation is more important than the absolute volume. Rapid accumulation of even small amounts can cause tamponade. Common causes include infective, often viral, for example Coxsackie virus, but may be bacterial or tuberculous. Trauma, blunt or penetrating injury to the chest. Malignancy, pericardial metastasis or hemorrhagic effusion. Post-MI, left ventricular rupture or Dressler syndrome. Renal failure, uremic pericarditis. Autoimmune diseases, for example SLE or rheumatoid arthritis. Symptoms: dyspnea, chest pain or discomfort, fatigue, palpitations, and lightheadedness or presyncope. Signs: Beck's triad, which is hypotension, raised jugular venous pressure (JVP), and muffled heart sounds. Pulsus paradoxus, a drop in systolic blood pressure of more than 10 mm of mercury during inspiration. Tachycardia, cold peripheries, and peripheral cyanosis in severe cases. Investigations. History and examination. Clinical suspicion is crucial, especially in at-risk patients with hemodynamic compromise. ECG. This may show electrical alternans, alternating QRS amplitude, due to the heart swinging in a fluid-filled pericardium. A low-voltage QRS complex may also be seen. Chest X-ray. This may show a globular or water bottle-shaped cardiac silhouette in cases of large effusion. Echocardiogram. This is the gold standard. This confirms pericardial effusion, chamber collapse, especially right atrium or right ventricle in diastole, and reduced ventricular filling. Pericardiocentesis. This is both therapeutic and diagnostic. Pericardial fluid can be sent for cytology, culture, and biochemical analysis, for example, protein LDH to determine the cause. Complications. Complications include cardiogenic shock, cardiac arrest, typically pulseless electrical activity, pulmonary edema, arrhythmias, and multi-organ failure due to hypoperfusion. Management. Immediate management includes IV fluids to maintain preload and support blood pressure while preparing for definitive treatment. Urgent pericardiocentesis is the first-line intervention to remove fluid and relieve pressure. In unstable patients, or if pericardiocentesis is not feasible, pericardial window surgery may be required, especially for recurrent or loculated effusions. Treat the underlying cause, such as infection, malignancy, or autoimmune diseases, to prevent recurrence.
That was just a preview. Watch the full video and hundreds more at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today